G'day everyone, my name's Peter Frampton. I'm an independent prescribing optometrist and I work in the northeast of England. And my talk today is called Dry Eye with a Twist, a re-evaluation. Now this is a talk that I can do quite easily actually because I actually really question how we approach dry eye. And I actually to some extent question how we are presented with dry eye by educators. And in the most polite possible way, I want to really question our models and how we approach this problem. Now, there are some extraordinarily good papers out there on dry eye. And the point is, if you want good papers, they're there. If I was going to just repeat these papers, then we might as well not do it. You might as well just read them. But there's some very good papers out there by Craig and Matheson, and of course the big one is the Jews report from 2007. That's a really good paper, but it is about 150 pages, so you might want to read the others. But they are extraordinarily good papers to read, and they're worth looking into. But I want to take it from a different angle, and I want to make no bones about this. I absolutely hate the term dry eye. Now, my dislike for this term has evolved over a long, long time. But it was galvanised a few years ago with a particular patient. She was a new patient to our practice. She came in, we did the normal general health issues, we were collecting data. She was not on anything particular systemically, no particular drugs, but during the general case workup she did comment that she had a dry eye and that she was being prescribed Visco-Tears. I made notes of all this, put it all down, and didn't think too much about it. Then swung the slit lamp around for my first white light examination in front of the eye, and honestly, her cornea was just a mass of epithelial erosion. The whole cornea, north, south, east, west, the whole lot. And I remember sticking my head around the slit lamp and looking at her and said, look, how often are you putting the drops in the Visco-Tears in? She said, well, actually my eyes are feeling so dry at the moment that I'm putting it in up to 15 times a day. Now, she didn't have a dry eye. It took us about 6 months to get her vision back to normal because her epithelium was so eroded from all the toxins inside the Visco-Tears. 6 years on, she doesn't use any drops at all. She doesn't have a dry eye. It's a mystery to me why she was diagnosed. I can only assume that sometimes she sort of commented to someone and said, look, I've got a slight irritable eye here, and as a sort of throwaway term said, oh yeah, you must have a dry eye. And since then she's been putting these drops in ever since, and it's getting worse and worse and worse. So I think as a descriptor, except under very special points, dry eye is at the very least misleading, but actually at the worst it actually engenders mismanagement of other ocular conditions. And I think we need to really be thinking about how we approach this problem. Here's some stats for you, for instance. Albert says a quarter of patients presenting for eye examinations have symptoms of dry eye. Only 3% though have tear deficient dry eye, and 40% have signs of meibomian gland dysfunction. She then has a good point. It says correct diagnosis is essential if the condition is to be managed appropriately, and that's the underlying point about this whole talk. And yet Mann says that mainstream treatment for dry eye still remains artificial tears, even though the majority is evaporative stress. Now that's somewhat worrying set of stats really if you think about it. Now it's not quite as bad as it appears, as I'll get to later. There's some really good reasons why we maintain lubricants and so on. But certainly it must make you think about how we're going to approach this problem. And the other point about all my talks, I slot this into everything. Dry eye is a very, very good way of introducing yourself to GPs. They want to be told what to do. And we want to tell them the real diagnosis and how to treat it. And then we can become the GPs of clinical practice, of community practice, and for heaven's sake, don't wait till you get a qualification. Don't think you've got to have an AS or an IP to do any of this. This is really good stuff, and we can all do it immediately. The other thing about this talk is that I don't want to mention any, apart from one thing, I don't want to mention any high-tech technology, expensive stuff. I want this to be a talk where, as of tomorrow, you can go out and start doing things, and this is really important. Now, the Jews report came up with, this is the global definition of dry eye now. If you're going to quote a dry eye definition, this is the one to be giving. And it says, dry eye is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability. And it is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. Now, what I want to suggest to you is It's not a multifactorial disease at all. It's a multitude of different disease processes that happen to give you a gritty feeling eye. The most important point about it, though, is the osmolarity, and this is really, really crucial now. We know if there's going to be one objective test you can do, actually, nowadays, rather than a subjective test that could definitively say this is dry eye, it's osmolarity. And that's why it's in it. And that's something we can all manage within the practices immediately. So the Jews report then, in a different section, gives you this sort of tree graph of all the different things that can cause what they call dry eye. And it's a complicated thing. And if you look at it, a lot of it, in my opinion, aren't actually part of dry eye. They even talk about contact lens wear or lid aperture disorders, meibomian glands, and these are separate entities. And so, if I could go through all of this individually and go through each piece, but really isn't going to help us. When you dig deeper into the Jews report, a guy called Vitali, who's written a lot of papers, he's done a lot of stuff on Sjogren's and so on. He wrote this interesting point: classification criteria are not necessarily appropriate for use in diagnosis and may lead to disclassification of a disease, particularly in its early stages. In an individual patient, a classification scheme can provide a guide, but an expert clinician, that's it, an expert clinician applying appropriate diagnostic criteria is needed to establish a diagnosis, and this is the point. We are clinicians now. We're not screeners. We're not recipe followers. We are clinicians in our own right, and we need to be doing this. And that was buried deep within the Jews' criteria. So therefore, dry eye, in my opinion, should be a diagnosis of exclusion. We have to make the diagnosis. If we do not get the diagnosis correct, how can we possibly expect to treat it appropriately? And this is part of the jigsaw that we have to put together. And if you've got the right diagnosis, you can then go down different avenues and try different things for people. Now, Jennifer Craig points out that careful assessment is key to adopting an appropriate management strategy. Be systematic, obviously. We know this, but it's so important. Now, my system might not be the same as yours, but so long as you're systematic and careful in your approach to it, obviously doing non-invasive procedures first and moving on to other ones. But have a bit of an approach yourself, do it yourself, find out what works for you, and then move on from there. So the first thing, obviously, from my point of view, is basically the case workup. You know, you're taking the symptoms, age, sex, general health medications, and this is really important. You know, you should use the BNF, you should use this thing called the Electronic Medicines Compendium, which I'll comment on later. And I think it's really important that we all start doing this. When you don't just take a list of drugs from a patient, put them in order, classify them, start getting familiar yourself with what drugs are for what things and why they work and how they work. You know, a classic one around here, everywhere over the country, is bendroflumethiazide. It's a thiazide diuretic, but it's actually used for blood pressure. But as a diuretic, it has to theoretically induce dry eye. And you'd start to get a feel for what drugs are for and how they're used. And I think this is really important. This only comes with time, and I think it's important. Ocular surgery, trauma, things like that, very important. Cosmetic surgery, in particular these days, can disrupt tear, lid function and so on. And this questionnaire is, now, I put this in specifically. The only questionnaire I use is the revised American European Sjogren's criteria. And I want to talk a little bit about questionnaires in a minute. But the other point is, of course, all the other things about allergies, smoking, computers, work environment, and so on. These are all part of our general case workup these days. And hay fever. I ask every patient if they get hay fever. And that's really important. And the number of people who do these days is amazing. But some of the resources, the BNF is really, really important. I think it's free. And I have it on my electronic, I have an electronic one, and I have it on my favourites. And you do have to register with the BNF, but it's free. You just say you're an optometrist, you get on it. And then you have it there, and it's always being updated. We're up to number 62 now. Every 6 months it gets updated to another one. You don't have to try to borrow an old one from a hospital somewhere. And the other really important thing, which is free, completely free to everyone, it's open to the general public, is the Electronic Medicines Compendium. And they give you two things. They give you a pill, which is a public information leaflet, but the thing you go into is the SPCs, the summary of product characteristics, and that will give you all the breakdown of every characteristic about a particular drug. So if you really want to investigate something, go straight to Electronic Medicines Compendium. I also mentioned this other thing called Milder Side Effects of Drugs, which is a tome of a book. Don't buy it, but I'll be mentioning it later. So, Craig does mention validated questionnaires, right? These questionnaires are around. Now, she says they're validated. She even makes a comment about the fact that they can possibly be even done in the waiting room before the consultation. And, you know, for a busy practice and large practice, they're really good apparently. And the patient responds to questions of assigned values, and that allows you to have some sort of grade of the dry eye. And she mentions McMoney's dry eye questionnaire and this other one, the OSDI. I've used the McMoney's. Now, my patient before, if she'd gone through that questionnaire, the McMoney's one, she would have been classified as pathologically dry because of her symptoms. And this is the problem I have with questionnaires. In the Jews report again, they say the sensitivity of these things is 98%. The false positive rate is only 3%. The specificity is 97%, and the positive predictive value is 85%. So it's good. But, and this is the but, they agree that their characteristics of dry eye questionnaire contribute to its suitability for epidemiological studies and randomized control trials. They also say that they're employed in clinical research. They do not say they're a diagnostic tool. And this is really, really important. If you go back to your case workup, there is no question